Cool. Ready? Ready. Subcommittee will come to order. Welcome to the Ways and Means Health Subcommittee Member Day hearing entitled Legislation to Improve and Sustain the Medicare Program. Today, similar to our last Member Day hearing on tax-related proposals to improve health care, this subcommittee is providing a public platform for any and all members interested, members of Congress, to discuss bills that they have introduced that modify the way health care is assessed and delivered to more than 55 million seniors who rely on the Medicare program. Members have put a lot of work into developing and drafting these pieces of legislation, and this Member Day hearing is their opportunity to share with their colleagues and the American people why these bills are important and why this committee should take them up. In addition to my colleagues from Ways and Means, I'm excited to hear from members who serve on other committees who've worked equally hard on legislation to transform and improve our Medicare program. We remain committed to working through regular order that includes hearings, like the one today, from those on and off the committee. So how is it going to work? Members will have 5 minutes to discuss their Medicare legislative priorities. And I'd remind those members that they are also able to submit written testimony in support of their legislation. We thank you all, witnesses and members of this subcommittee, for taking the time out of your busy schedules to be with us today. And I hope, Dr. McDermott, we can build on the kind words you said about us yesterday. I knew it might take a little while for you to say kind words about us, and we accomplished that. So let's build on that, sir. I yield to the ranking member.
Thank you, Mr. Chairman. We might as well start out on a good note. And I think that I want to thank you for holding this Member Day hearing to improve and sustain Medicare. I welcome this opportunity to learn more about the ideas that my colleagues may have, and they will discuss today. When it comes to Medicare, the policies which were put in place in 1965, those policies, we've made a wide range of interests, physicians, insurers, hospitals, and many others. And the most important people affected, however, by Medicare are the beneficiaries. The 55 million seniors and Americans with disabilities who depend on Medicare for their health care. At its core, Medicare is a fulfillment of a commitment to the health security of the American people. Individuals who have contributed to the system deserve the peace of mind of knowing that Medicare's benefits will be there when they need them. That means that Congress must work to ensure that Medicare truly strengthens the quality and accessibility of beneficiaries' health care. A strong Medicare doesn't mean we turn the program over to the insurance industry, and it doesn't mean we shift more costs onto the beneficiaries. A stronger Medicare is a program that provides comprehensive coverage to beneficiaries at affordable costs. To make that a reality, we have to move the conversation in Congress away from harmful ideas like privatizing the program and cutting seniors' benefits toward a more productive discussion of how to make Medicare work better for beneficiaries. To that end, I intend to discuss legislation I have recently introduced, which will provide beneficiaries with access to comprehensive dental, vision, and hearing services. This is a popular, long overdue reform that will improve the health security of millions of Americans. And I look forward to talking further about the importance of this during the hearing. I also hope to hear from my colleagues about other ideas that will continue to build upon and expand Medicare. I intend to carefully scrutinize ideas that may not be in the best interests of the program or the beneficiaries. Today's hearing is a part of what must be an ongoing process of careful debate that will show the American people what Congress is doing or not doing to improve health security. When Medicare was put in place, the life expectancy in this country was about 10 years lower than it is today. So we've had such success in Medicare that we've got a whole lot of new problems that we didn't have before. It must be followed by substantive legislative hearings and markups and amendments so that we can weed out bad ideas and make sure the ones are good can have the passage of this Congress. Thank you again, Mr. Chairman, for bringing this day together, and I look forward to hearing the witnesses.
Thank you, Dr. McDermott. Without objection, other members' opening statements will be made part of the record. Now we'll hear from members of the subcommittee on their priorities to improve Medicare. I am the lead Republican on the Medicare Home Infusion Site of Care Act, which we are working with the Senate and CMS, working with them both on to ensure it will work for all stakeholders. It's truly an important piece of legislation that will expand beneficiary access to infusion treatments in their homes if that is where they choose to receive their care, something that private providers already cover. I look forward to continuing to work on this legislation that will increase beneficiary access to appropriate and cost-effective care and advancing it when it is ready. With that, I turn to my left, literally, to Dr. McDermott once more for the purposes of discussing his legislation. Dr. McDermott, you are recognized for 5 minutes.
We welcome you on the left. I would like to ask unanimous consent to enter into the record a letter from the Medicare Rights Organization dated 8 June 2016.
Without objection. Without objection.
Mr. Chairman, I've sat here on this committee for 25 years and watched lots of things happen, and I'm really glad that we're having a hearing today when we could put some ideas up on the table that we haven't had before. I'm introducing today a bill called the Medicare Dental, Vision, and Hearing Act, a bill I introduced, I guess, yesterday, actually. The creation of Medicare in 1965 was one of the great policy achievements in the history of this country. The benefits that Medicare provided ensured that 55 million citizens and their people with disabilities would enjoy the peace of mind and the security that comes with having quality health coverage. The best way to improve and sustain Medicare is by expanding it and strengthening it, because unfortunately there are holes in the program that weaken the health security of our beneficiaries. One of the largest holes in the Medicare system is that it does not currently cover most dental, vision, or hearing expenses. In fact, not only does it not pay for these crucial health services, they are specifically excluded from coverage by the statute that was passed in 65. This is a misguided policy that for decades has had harmful consequences on beneficiaries. Doing without dental coverage frequently leads to preventable health problems. Patients who have poor or no dental care often find themselves suffering from costly and potentially fatal conditions such as cardiovascular disease and oral cancers. We had recently here in Washington, D.C., a young kid who didn't have dental care and got encephalitis of the brain from an infected tooth. Now, similar untreated vision disorders substantially increase the risk of falls among senior citizens. One of the biggest problems for senior citizens is falling. And if they got bad vision and don't have glasses, or they got cataracts or whatever, they are having trouble. These falls can result in serious injuries and expensive hospitalizations. Hearing loss, for those of us who grew up in the age of rock music and used to stand next to the woofers and the tweeters at full volume, today have hearing aids because we did things with our ears that we didn't understand then. There are lots and lots of seniors who have hearing loss, and that is an isolating event. When you have no ability to hear, you are cut out of everything. And that's why it is, if we are having seniors live longer and longer and longer into their 80s and 90s, we're going to see more of the hearing and the vision loss that we have not dealt with in the past. It's a widespread, the hearing loss is a widespread among Medicare beneficiaries, often leading to social isolation, depression, and cognitive impairments. We wind up treating them for depression, we treat them for all kinds of other things, basically because they can't hear. Yet research shows that a majority of the elderly who need hearing aids do not have them, in large part due to cost. That's why the reforms made by the Medicare Dental, Vision, and Hearing Benefit Act are so important. This bill modernizes and strengthens Medicare's benefit package to address the full spectrum of beneficiaries' health needs. It amends Part B to provide coverage of important health services, including routine and major dental care, refractive eye exams, and hearing exams. It adds coverage for important supplies, including dentures, glasses, and hearing aids. It repeals the harmful statutory exclusions that prevent Medicare from paying for these costs. And to control costs and ease the burden as we implement these major reforms, it places reasonable limitations on coverage and provides that new benefits will be phased in gradually. All too often at this committee, our policy discussions focus on how much we can cut from Medicare and how to further shift the costs onto beneficiaries. In the process, we fail to recognize the possibilities before us and the enormous power we wield. The truth is the Medicare must be strengthened, not cut, and benefits must be expanded, not scaled back. As the Ways and Means Committee, we owe a duty to the American people to discuss how we can make that happen. And I yield back the balance of my time.
Thank you.
The Chairman.
Thank you, Dr. McDermott. My phone was ringing, and I was thinking it was my mom and dad calling me about your legislation there. Very well done. Mr. Roskin is,
Mom and Dad.
yeah, Mr. Roskin is recognized for 5 minutes.
Thank you, Mr. Chairman and Ranking Member McDermott. 5 minutes, 3 bills. Let me do this quickly. Buckle up. I think I can do it. So H.R. 512 is the Disarm Act, and it's designed to incentivize the development of new antibiotic drugs. The administration recognizes that we have an incredible problem here. The CDC recognizes that we have an incredible problem here. And the incredible problem is that we've got infections that are unwilling to yield to some of the antibiotics, and we don't have enough incentive out there in the private sector to invest, essentially. And this is a plague. Let me just give you one quick example. In March and April in the Midwest, 18 people died from 57 infections in 3 states. And this is here, it's upon us, and we need to deal with it. H.R. 512 would address this by reimbursing hospitals for the costs of acquired new certain agents. It passed in Chairman Upton's Cures Act. We'll see where that is in the Senate, Mr. Chairman, but my view is that we would be wise to reclaim jurisdiction here and move it again. Bill number 2, H.R. 3220, the Common Access Card. This is a bill that I've introduced with Mr. Blumenauer. Some of the work of the Oversight Subcommittee has shown that the fraud and erroneous payments rate at Medicare is 12.7%. I mean, it's just this shocking figure. And you begin to ask yourself, how is this possible? Well, it's impossible in part because we've got these flimsy old Medicare cards and it's a bunch of nonsense. And what we're proposing is this, to take the technology that the Department of Defense uses currently, try a pilot program, and create a common access card. Ready for a statistic? February 2016, a few months ago, GAO revealed that 22% of healthcare fraud cases ultimately prosecuted by the federal government could have been prevented by use of a smart card. 22%. Marinate in that for a second. When we're running around here, grubbing around, looking for nickels and dimes, thinking about 22%, thinking about 12.7%, you take my point. So here's what we need to do. We need to pass this bill, number 1, but you need to give us good feedback. I spoke with Secretary Burwell this week. She is committed to expediting a meeting to get stakeholders together, and I think we can do a lot of good work here. And Dr. McDermott, I'm looking to you to get on this bill. And then finally, the H.R. 4853 is the SAFE Act. And in a nutshell, this legislation provides CMS with additional flexibility to permit approved private sector accreditors to use their own updated standards and survey processes for hospital accreditation. So in other words, we've got the private sector that's doing a fabulous job. We've got a statute that basically tethers us to an old system. So let's dump the loser stuff, pick up the things that work, and let's adopt it so that these hospitals can move forward in that basis to allow accrediting bodies to use assessment methods that incorporated the latest best practices in healthcare delivery to ensure hospitals adhere to high-quality standards and patient safety. And Mr. Chairman, who doesn't love that? And I yield back.
Well done, Mr. Roscom. Thank you very much. Before I yield to Mr. Davis for 5 minutes, I just want to thank him for coming down to the floor yesterday and his kind words on the bill that originated in this subcommittee, and thank all the members for their input on a bill that passed the floor unanimously yesterday. So with that, Mr. Davis, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and I shall discuss H.R. 2124, the Resident Physician Shortage Reduction Act, introduced by Representatives Crowley and Bustani. Mr. Chairman and Ranking Member, the Illinois 7th Congressional District, which I represent, contains the most hospital beds of any congressional district in the nation, and is also home to 4 major academic medical centers. Given our nation's growing and aging population, coupled with the coverage expansion contained in the Affordable Care Act, the demand for health care continues to increase, especially for those with complex health care needs, such as the fastest growing population in the nation are those aged 75 and older. Recent studies show that our nation will need as many as 90,000 new physicians over the next decade, and as many as 63,000 of which who will need to be specialists. Clearly today, more than ever, Congress should maintain and enhance our nation's investment in training tomorrow's physician workforce. Given that it takes anywhere from 5 to 10 years to train a physician, the question facing Congress is, what are we doing to ensure that our nation is physician workforce ready to meet our nation's healthcare needs both today and in the future? The teaching hospitals in my district are incurring the cost of these programs significantly greater than the direct and indirect graduate medical education payments they receive. In fact, most of the major teaching hospitals in Chicago are training in excess of 100 doctors over the residency cap, which costs tens of millions of dollars that will never be reimbursed to those institutions for training more physicians to address the growing shortages in primary care and acute surgical specialties. Medical schools and teaching hospitals are also working to ensure that new doctors coming into the system are trained to serve in new delivery models that focus on care coordination and quality improvement. According to the latest physician workforce projections, roughly 2/3 of the shortage in coming years will be in specialty practice areas such as neurology, pediatric subspecialties, geriatrics, and oncology. We need more doctors and allied health professionals to assist a healthcare system that for decades was not adequately addressing health disparities among millions of racial and ethnic minority Americans. Many of our minorities are disproportionately more likely to suffer deleterious health disparities just because they are low-income wage earners, poor in health, and suffer worse health outcomes, and are more likely to die prematurely and often from preventable causes compared to other members of the population. This bill provides a greatly needed opportunity to train the physicians that we need throughout our country. I'm delighted that Representative Crowley and Representative Bustani have collaborated to pass it, and I would urge all of my colleagues certainly to be in support of it. And Mr. Chairman, I thank you, and yield back the balance of my time.
Thank you, Mr. Davis. Dr. Price, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and appreciate the opportunity to discuss bills relating to a very important subject, and that is the issue of saving and strengthening and securing Medicare. The demographic challenges that we have in this country are huge, and Medicare is running out of resources. As you well know, that's according to their own trustees. The challenge that we have right now is that CMS is saving money, according to them, by decreasing services and limiting access to care, and it's happening right now. It's not happening just in a fictitious way potentially in the future. I want to talk about three pieces of legislation. The first is H.R. 5210, which deals with durable medical equipment, patient access to durable medical equipment. CMS instituted what's called a competitive bidding program for suppliers of durable medical equipment that is not either competitive and isn't bidding. And it isn't because it doesn't hold bidders accountable, it doesn't ensure that bidders are qualified to provide the products in the bid markets, and it produces bid rates that are financially unsustainable. Mr. Chairman, this literally is harming lives as we speak. Essential services, including oxygen, are being denied to patients because of difficulty gaining those services. In rural areas, it's a huge problem. Many rural areas of the country, the amount paid for these services doesn't even cover the cost. So you get decreased availability. In Georgia, for example, 20% decrease in the number of DME suppliers in the last 3 years, and a nearly 40% reduction in medical equipment supply stores in our state just in the last 3 years. Patients' lives are literally at risk. The National Minority Quality Forum has data that demonstrates that it's driving up costs by avoidable hospital bills and increasing out-of-pocket payments by patients. It's led to increased mortality. That means death and hospitalizations, and a higher cost for Medicare beneficiaries. OIG for Medicare itself said that CMS paid over $1 million to 63 suppliers for product categories they weren't even licensed to provide in their state, over $1 million. So H.R. 5210 would simply delay the onset of this competitive bidding program and expanding the onset of the program. And that's a bipartisan supported bill. Second is H.R. 4848, the Healthy Inpatient Procedures Act, called the HIP Act. As an orthopedic surgeon, I bear some familiarity with this area. This is talking about the Comprehensive Care Joint Replacement, or CJR model. This is something that CMS put in place to try to decrease amount of resources spent on lower extremity joint replacements. The problem is they've gotten it all wrong. It is what they call a demonstration product, but it's the first mandatory demonstration product. So how it can be a demonstration product and be mandatory is beyond me. 60% of the hospitals is estimated will be penalized because of this. Decreasing resources available for patients to utilize for lower extremity joint replacements. So what happens? Medicare, CMS limits access, limits choice, increases consolidation of services, and therefore increases prices. What does this mean to patients? As a formerly practicing orthopedic surgeon, I would talk to patients about what kind of replacement they ought to have. And Medicare may or may not agree with that. The problem with this program is that if Medicare doesn't agree with that, then guess who doesn't get the joint replacement that they need? It's the patient. So the H.R. 4848 would delay onset of this program till January 2018. Again, it's bipartisan support. It would simply give us time to give docs time to get ready for it, to give us an opportunity to modify this program. And then finally, H.R. 5001. Everybody has heard from their docs about the issue of electronic medical records. It is a disaster for physicians back home. The amount of time that they're having to spend on this to simply comply with regulations that don't increase the quality of care to patients is astounding. What Medicare did this year is to change the meaningful use reporting period from a 90-day period, rolling 90-day period where docs would have to comply, to 365 days, which means the entire year, which means you can't have your server go down, you can't have any problem at all throughout the course of the year, or you get dinged by Medicare for not having what they believe is the appropriate electronic medical record. This solution would return it, this bill would simply return it to the 90-day reporting period that we've had in the past. Again, common sense, bipartisan. I appreciate the opportunity to present these and look forward to them passing.
Thank you, Doc. With that, Representative Buchanan, Florida is recognized for 5 minutes.
Thank you, Mr. Chairman, for holding this important hearing. Before discussing my legislation, I'd like to mention the importance of examining medical competitive bidding also, as Dr. Price has clearly taken the lead on this, but it has a huge impact to my region in Florida, especially Sarasota, but all through Florida. A lot of diabetics are very concerned about the impact it's going to have on them going forward. So I appreciate, Dr. Price, your leadership, and hopefully this is something we can get done quickly. Now, as for my legislation, along with my good friend Congressman Pastorell, I introduced the Preserving Patient Act, to Post-Acute Hospital Care Act, H.R. 4650. Right now, tens of thousands of Medicare patients rely on access to highly specialized care facilities known as long-term acute care hospitals, or LTACs, after they are released from intensive care units. These facilities are uniquely equipped to care for chronically ill patients over an extended period of time. And unless Congress acts, the allowable caseload for these facilities will be cut in half January 1st, 2017, so in 6 months it would be cut in half. This means people will either remain stuck in the hospital ICU longer than they want to, or be forced to move to another place away from their homes and families to find care that they need. My bill prevents this cut from taking place, and Congress has approved similar measures several times over the last decade. We need to act soon. The cut takes effect at the end of the year, but these facilities need time to plan for their patients' care. If we fail to pass this bill, more than 100,000 seniors could be denied vital care at their local ATAC hospital. And with that, I yield back.
Thank you, Mr. Buchanan, and thank you for bringing up Dr. Price's bill. I, too, share that concern with respect to the durable medical goods issue, and have had constituents in my region of Ohio express concern, so look forward to working with you on that, Dr. Price. Ms. Jenkins, CPA Jenkins, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you for holding this important hearing and allowing me an opportunity to speak on bipartisan legislation that I'm proud to advocate for that will allow more beneficiaries to access vital care in rural areas, save Medicare patients and the system money, and ensure its stability for generations to come. H.R. 12012, the Medicare Patient Access to Hospice Act, which I introduced with Congressman Thompson, will allow physician assistants to receive reimbursement from Medicare as the attending physician in a hospice setting. Hospice care is incredibly important in my district because of the lack of hospitals and doctors' offices that urban districts have with large health systems. Along with allowing physician assistants the ability to perform cost-saving medical care in hospice setting, H.R. 1784, the MEND Act, which I introduced with Congressman Tonka, will bring about an out-of-date CMS regulation in line with the accreditation body that allows hospital-based nursing programs to produce nurses and shore up critical shortage in the Medicare system. A third bill, H.R. 2138, the Medicare Access to Rural Anesthesia Act, which I introduced with Congressman Cleaver, will pay anesthesiologists in certain rural hospitals under Medicare Part A for their services at the rate paid to a certified registered nurse anesthetist in those hospitals for the same services. As I pointed out with H.R. 12012, Medicare beneficiaries in Kansas must use entire days sometimes to travel to certain hospitals to get care. Many of those hospitals can't afford a full-time anesthesiologist, so those folks are then forced to travel somewhere else to get care. H.R. 2138 will help eliminate that burden and allow more rural hospitals to hire and keep anesthesiologists on staff. Similarly to that bill, H.R. 3355, which I introduced with Congressman Lewis, will allow physician assistants, nurse practitioners, and clinical nurse specialists to supervise cardiac, intensive care, and pulmonary rehabilitation programs. Again, this will allow critical access and rural hospitals to hire and keep these vital staff members and provide needed care to rural parts of Kansas and the United States. Americans living on farms and ranches in those rural areas have the same need for medical services as those living in urban areas, and this legislation will give them more adequate service and keep costs down for the patients and the whole system. I'll continue to work to give rural Medicare beneficiaries better access to care and save the entire Medicare system precious dollars so they can stay solvent and effective for generations to come. These 4 bills will make it much easier for Medicare beneficiaries to access and afford the care that they need, especially in rural parts of the states. I strongly encourage my colleagues to support these pieces of legislation and help me bring them to the House floor. Thank you, Mr. Chairman, and I will yield back.
Thank you, Ms. Jenkins. Representative Marchant is recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks for having this hearing and allowing us to put forward our ideas. I introduced H.R. 3288 with my friend and colleague, Dr. Bustani, last year. This legislation amends Title 18 of the Social Security Act to change the method of determining disproportionate share hospital payments under the Medicare program. As the members of this committee are aware, DISH payments compensate hospitals for the above-average operating costs they incur in treating a large share of low-income patients. Mr. Chairman, 19 states have decided not to adopt Medicaid expansion. DISH hospitals in each of these states, such as Texas, Florida, Tennessee, Kansas, and Georgia, are financially disadvantaged by this. Though it is not our job to make state-level decisions, it is our job to ensure our hospitals have the resources necessary to care for our constituents. My bill would help ease the burden these hospitals are facing. Patient care is not a partisan issue, and I urge all of my colleagues on this committee to co-sponsor this nonpartisan, no-cost policy. Mr. Chairman, once again, I appreciate the effort being made here today and for the forum to speak on ideas to sustain Medicare, and look forward to continuing to work with you and the committee to advance the policy and strengthen the DISH program. Thank you. I yield back.
Thank you, Mr. Marchant. Representative Paulson from Minnesota, recognized for 5 minutes.
Thank you, Mr. Chairman, also for holding this hearing. I have two bills that I have introduced I would like to touch on today that have bipartisan support and would benefit seniors on Medicare. The first is H.R. 5075, the Accelerating Innovation in Medicine Act, also known as the AIM Act, which I introduced with Representative Ron Kine. Currently, patients and providers are having trouble accessing the newest, most innovative medical technologies, and more barriers are coming from CMS rather than from the FDA. And we as a committee need to take a serious look at the CMS coding, coverage, and reimbursement process to examine how the agency is functioning, its impact on the biomedical ecosystem, and its effect on ensuring that patients will have access to the next generations of advanced therapies. Currently, the process of receiving a CMS code alone can take as long as 3 years. National coverage decisions are typically time-consuming and cumbersome, and some new therapies must go through a process of convincing each local carrier to provide coverage before a patient or a senior can get access. This process delays patient access to groundbreaking treatments. My bill, the AIM Act, would focus on the front end of this process by increasing patient access to new FDA-approved medical devices and procedures and speeding up the collection of data needed for Medicare coverage decisions. The AIM Act does this by allowing a manufacturer to place FDA-approved devices and treatments on a list where they are available for Medicare beneficiaries that self-pay. By agreeing to not seek Medicare reimbursement for 3 years, the devices then will be available without government red tape, paperwork, and administrative costs. And during that 3-year period, the manufacturer could collect patient data that will help streamline a future Medicare coverage decision. The current system is expensive, it's inefficient, and it gives providers, patients, and manufacturers uncertainty. And we need legislation like the AIM Act so that we can ensure the continued development of new treatments to improve Medicare outcomes, efficiencies, and lower costs. And then, Mr. Chairman, the second bill is H.R. 2404, the Treat and Reduce Obesity Act, that I've also introduced with Representative Ron Kine. Obesity is now an epidemic and a public health crisis that needs to be addressed. Over 40% of seniors are obese. This disease takes both a physical and an emotional toll on an individual and often is the cause of many other chronic conditions like diabetes, heart disease, stroke, and others. Nearly 20% of the increase in our healthcare spending over the last 2 decades was caused by obesity. And this disease directly costs Medicare more than $50 billion a year, and that number will continue to increase over the coming years. This is bad for our seniors, and it's bad for Medicare. Unfortunately, there are limitations in place preventing patients from accessing important treatments and providers that can help them combat obesity. The Treat and Reduce Obesity Act would remove these barriers by giving patients access to FDA-approved obesity drugs under Medicare Part D and allowing additional qualified healthcare practitioners to provide intensive behavioral therapy services. Patients and clinicians require access to the full range of proven, safe, and effective therapies for the treatment of obesity. We have the ability to save the healthcare system billions of dollars and, at the same time, make the lives of patients significantly better. And that's why this bill has nearly 150 bipartisan co-sponsors. We can't solve this problem overnight, but by taking action now, we will help us solve our obesity crisis over the long term. And finally, Mr. Chairman, I just want to touch on another issue that I'm working on. I recently held a roundtable in Minnesota with some hospitals, and they're concerned about the direction that Medicare is going in terms of too much regulation, too many requirements, and the reimbursement system being very unpredictable. Hospitals, providers, and patients all recognize that we need fundamental reforms to the system, otherwise the system will collapse and seniors will suffer. And thankfully, there are providers, health plans, and states out there that are now trying to find ways to make our healthcare system more efficient and effective. They're not trying to tie the healthcare system up in knots with duplicative process measures that may or not yield the best results, but they are focusing on outcomes, high-impact, clinically credible outcomes that we can focus providers around to achieve substantive and sustainable improvements for patients. And we can learn a lot from these state and local initiatives to strengthen Medicare. I look forward to working with you, Mr. Chairman, and my colleagues on those efforts to do just that. Those are just several of the ideas that I have for reforming Medicare, and I look forward to working with the chairman in the future on these bipartisan ideas. I yield back.
Thank you, Mr. Paulson. We are now fortunate to be joined by members of the full committee who have some ideas of their own on health care. Welcome, everybody. How is it down there? Not bad?
It's doing well.
The view, I'm not sure.
Well, let's start with the gentleman to my far left. Mr. Dole, you are recognized for 5 minutes to share your ideas with us.
Thank you, Mr. Chairman. I appreciate the comments from my colleagues down here on your comments. But anyway, Mr. Chairman, I thank you for the opportunity to testify before you today on 2 bills that I think will make some critically necessary reforms to Medicare. The first I'd like to speak about is H.R. 5122, a bill that I helped introduce alongside my colleagues, Dr. Bouchon, Dr. Bustani, Dr. Price, and Representative Shimkus. This legislation would prevent CMS from finalizing, implementing, or enforcing the demonstration program they proposed on March 8th of 2016. The proposal will dramatically alter the way Medicare Part B reimburses physicians for medications they administer to seniors in outpatient settings. The resulting cuts could disrupt access to medications for our most vulnerable seniors, including those with cancer, arthritis, and other very serious diseases. As you are all aware, this proposed demonstration was developed by the Center for Medicare and Medicaid Innovation with very little transparency and limited input from patients and physicians. Unlike previous CMMI demonstrations, all Part B providers are required to participate. As a direct result of the demonstration, by Phase 2, 75% of all providers will see drastic cuts to their reimbursements when providing Part B covered medicines to patients. It also appears that CMS has failed to fully model how this demonstration will interact with other programs, especially the implementation of macro legislation passed to repeal the SGR. Thanks to the ingenuity and perseverance of incredible researchers, our modern medical system has moved away from a one-size-fits-all treatment and has progressed into an era of precision medicine where treatments are highly personalized for each individual patient. The proposed demo or demonstration project directly contradicts this progress by incentivizing doctors to provide older, less advanced treatments rather than newer, more innovative options. By allowing this demonstration to proceed, we are putting physicians in a very difficult position that not only is unfair but detrimental to patient care. This will be especially true for providers working in small clinics serving rural areas. When the federal government created Medicare 50 years ago, Congress made a commitment to America's seniors, and the cuts embedded in this demonstration project are a betrayal of that commitment. We must stop this ill-conceived proposal and uphold our commitment to protect health care for seniors. I'd also like to speak with you today about another bill that will ensure seniors receive the best care possible. It's H.R. 1178. The Ensuring Equal Access to Treatments Act, sponsored by my friends Representative Reed and Representative Kind. It improves the way that CMS pays for certain diagnostic procedures that have a discretionary drug component by altering the current one-size-fits-all approach, which does not allow seniors to receive the personalized care that best meets their needs. In 2014, outpatient prospective payment system had a rule that CMS redefined in terms of packaged payments for certain drugs administered with corresponding procedure. Rather than reimbursing for the drugs and the procedure separately, CMS now uses one package payment, which includes the drugs and all other services and supplies associated with the procedure. Unfortunately, since the package payment is the same whether or not the drug is used, the new payment structure has the effect of encouraging healthcare providers to choose treatments which may not result in the best long-term outcome for the patient. H.R. 1178 corrects the problem by requiring CMS to create two separate payment codes, one for when the diagnostic procedure is performed with drugs and another when it is performed without drugs. We have already seen cases where 2014 packaged payments is negatively impacting vulnerable seniors. One example concerns the diagnostic of coronary heart disease. Providers have two options to raise a patient's heart rate to a specific target: a stress test on a treadmill or a stress test by an induced drug, which may be needed for those that are unable to get on a treadmill to raise their heart rate. The current package payment system provides an incentive for providers to choose the free treadmill test over the drug, even if the drug may be more appropriate. I believe we have an obligation to correct this misaligned incentive so that patients receive the most appropriate care necessary. We have seen a similar problem when physicians choose whether to diagnose bladder cancer with the new innovative procedure known as a blue light cystoscopy or an older, less advanced white light test. We made a commitment to provide America's seniors with high-quality health care through Medicare programs. I look forward to working with all of you on H.R. 5122 and H.R. 1178 and the other bills that have been presented here today in order to ensure that we maintain our commitment to our seniors. I thank you.
Thank you, Mr. Dolan. Thank you for your leadership in trying to stop that Part B demonstration program being proposed. It's important for us to try to do that. Look forward to working with you in that attempt. With that, Sheriff Reichert, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and I want to thank Chairman Tiberi and Ranking Member McDermott for being here today and holding this hearing and listening to our initiatives that we've been working on. I'd like to talk about a couple of bills. First, I'd like to talk about H.R. 2649, and this bill was introduced with Representative Mike Thompson, and it's assisting Medicare beneficiaries who have been injured on the job, filed a claim for workers' compensation, and settled their claims. In these settlements, an amount must be set aside to cover Medicare's share of future medical expenses related to the injury. The problem is that there are no statutory or regulatory provisions defining how these set-aside amounts should be determined, and the current procedure used by CMS has been subject to change without reasonable notice to the parties involved. This broken process results in delays and hardships for injured workers. My bill establishes a clear and predictable process. A few ways it accomplishes this is by setting a time frame for CMS to review set-asides, providing an appeals process, and also offering individuals the option to pay the total set-aside amount directly to CMS. So I look forward to working with you on this bill in advance. It's one of the priorities that we've been discussing both on the D and the R side. The next bill is one that, Mr. Chairman, you and I have talked about. It's the Lymphedema Treatment Act. This is 1608. I introduced this bill with Mr. Blumenauer. Lymphedema causes painful swelling in parts of the body where the lymph nodes or vessels have been damaged. While there are many causes, damage from cancer treatment is probably the most common. While there is no known cure for lymphedema, it is treatable. But sadly, Mr. Chairman, current Medicare law leaves patients without access to treatment items they need to manage the swelling and prevent further health complication. My bill will fix this by providing coverage of doctor-prescribed compression supplies. This will not only save lives but improve patients' health, but it also will strengthen Medicare program by reducing costly hospital stays. For example, Sarah from Ohio. When she was diagnosed with lymphedema, she was on the verge of losing her mobility and suffered frequent episodes of cellulitis. Between 2002 and 2004, she was hospitalized more than 10 times. In 2005, she was prescribed her first pair of compression garments. And by wearing these garments on a daily basis, she was able to maintain the progress she's made through treatment, manage her lymphedema so well that she has not been to the hospital in over a decade. Bob from New York, in 2000, he was hospitalized twice with potentially fatal cellulitis infections. Later that year, he was diagnosed with lymphedema. He received treatment and was prescribed the compression garments. In the 16 years since, he has not had another cellulitis attack and has not been to the hospital. Now, we can talk about whether or not this is expensive, because that's what, of course, the administration's argument is and Medicare's argument is, but we're saving a lot of money by providing these garments to these patients who have suffered through and survived cancer, saving money at the back end on other treatments and hospital stays. And not only that, it is the right thing to do for these patients. So I want to thank members here today who have already co-sponsored this bill. I'd like to recognize the patient advocates who have taken the time to meet with their members and share their stories. Thanks to their tireless efforts, the bill now enjoys, Mr. Chairman, over 230 bipartisan co-sponsors, and now we're working to even get more. And I ask, Mr. Chairman, unanimous consent to enter into the record a statement from the Lymphedema Advocacy Group.
Without objection.
The bottom line here is these are not defined by Medicare as medical devices because they don't fall within the definition of long-term durable devices, which is 3 years, because in most cases, the patients have to have new garments every 6 months. They're not disposable medical devices because they keep them 6 months and not a few weeks or a few days. This is ridiculous, a ridiculous rule, Mr. Chairman, and this bipartisan piece of legislation changes this rule and helps these patients get the treatment they so desperately need. Thank you. I yield back.
Thank you, Sheriff. Now representing the entire South Dakota delegation in the House, Representative Christine Ohm.
It's a big job. Thank you, Mr. Chairman. And thank you, Ranking Member McDermott and members of the subcommittee for holding this hearing and allowing me to talk about a Medicare bill that I am promoting. I'm here to discuss H.R. 4277, the Medicare Mental Health Access Act. I introduced this bipartisan bill with my Democratic Representative Jan Schakowsky. Now, Representative Schakowsky has been a leader on mental health care policy. She's a member of the E&C committee, and I want to thank her and her staff for all of their hard work on this issue as well. As you know, millions of Americans lack adequate access to mental health services, and it's especially true for thousands of seniors who age into Medicare every day. The federal government should be working to improve access for these individuals, but sadly, current law does exactly the opposite. In fact, it presents significant barriers to American seniors who seek mental health services. The problem is that seniors have to go through a middleman to get care. And that's because Medicare requires that many services provided by clinical psychologists must be prescribed and monitored by a medical doctor, a doctor who may or may not have any experience or training in mental health care. This supervision requirement is outdated, and it stands in stark contrast to the private sector, in which clinical psychologists are largely allowed to provide treatment independently. That requirement also fails to respect clinical psychologists' rigorous training and licensure requirements, which includes years of study in obtaining a PhD. This requirement is especially harmful for rural and underserved areas like South Dakota. When a physician is not available to oversee a clinical psychologist treatment program, the services are simply not offered. My bill, H.R. 4277, makes it easier for seniors to obtain mental health care services that they need, and it puts clinical psychologists on equal footing with other non-physician providers, like chiropractors and optometrists. They are easily accessible by Medicare beneficiaries. In short, the Medicare Mental Health Access Act amends Medicare's definition of physician. It includes clinical psychologists. This would have the effect of removing the middleman from the process of seeking mental health services and allowing seniors to go directly to clinical psychologists. It's also important to note that while this adds clinical psychologists to the physician definition, it would not allow clinical psychologists to become medical doctors. Rather, it would simply allow them to practice in a more independent way by removing that physician supervision requirement. I'd like to thank Mr. Nunes, Mr. Kine, Mr. Blumenauer, the subcommittee members who have already co-sponsored this important bill. I urge the rest of you to join them because the Medicare Mental Health Access Act represents a huge opportunity for us. It'll tear down barriers for mental health care access for our seniors, where in states like South Dakota, we see it being a real issue for them getting the kind of care that they need. I sincerely hope the committee will take up this bill as soon as possible. And again, Mr. Chairman, I thank you for the opportunity to testify today.
Thank you for your leadership on these important issues. Mr. Renacci, thank you for your leadership on the readmissions issue that became part of a bill that we passed unanimously on the floor last night. And we recognize you for 5 minutes.
Thank you, Mr. Chairman, for holding this hearing. I'm grateful for the many bills that my colleagues have and will present today. Indeed, I'm a proud co-sponsor of many of them. I also think it's important we are here today presenting proposals and continuing the conversation on how we can improve the delivery of services through Medicare and healthcare systems in general. When it comes to seniors, for instance, too often they decide not to seek the care they need because of the price, the inconvenience, or the bureaucratic red tape which gets in the way. There are so many burdensome and confusing regulations which many times leave Medicare beneficiaries waiting for a level of care they need or potentially facing extremely large bills they thought Medicare was covering. For example, under current Medicare payment policy, even if a physician knows the proper care setting for a beneficiary is a skilled nursing facility, the beneficiary must be admitted to a hospital staying at least 3 days as an inpatient in order for Medicare to cover the cost of the beneficiary's stay in a skilled nursing facility. Many times the beneficiary's personal doctor is also on staff at that same hospital, so already knows the level of care needed before they are admitted. Even more concerning is that oftentimes patients are not actually admitted as an inpatient and are only admitted under observation stay. Despite most not knowing their status, most beneficiaries actually see no difference in care while at the hospital, but are penalized for non-payment if later admitted to a skilled facility. Unlike other post-acute care settings, Medicare requires a 3-day inpatient hospital stay to qualify for skilled care, causing confusion for beneficiaries. According to an OIG report, in 2012, beneficiaries had over 600,000 hospital stays that lasted 3 nights or more, but did not qualify them for skilled nursing facilities, meaning these individuals were either outpatient or observation status during the hospital stay. Because they did not have the 3 days of inpatient care, as confusing as it sounds, they did not qualify for skilled nursing care due to the inpatient requirement, and they are left incurring tens of thousands of dollars of costs that are not reimbursed by Medicare if they end up going to a skilled facility. In order to protect access to rehabilitation services, I have introduced a bipartisan bill, H.R. 290, the Creating Access to Rehabilitation for Every Senior. It's called the CARES Act. It waives the 3-day inpatient stay requirement for skilled nursing facilities that meet certain quality measures. Here's an interesting fact. The average 3-day inpatient hospital stay in many cases is equal to or sometimes more costly than the average 27-day stay in a skilled nursing facility, and we burden our Medicare system with both levels of cost. Even private insurance companies have already eliminated this unnecessary and duplicative expense, the 3-day requirement. Therefore, by eliminating the 3-day inpatient requirement, Congress can save both the beneficiary and Medicare, the Medicare system, money by reducing unnecessary hospitalizations. I understand this issue. I operated skilled nursing facilities for over 28 years. Just like many of the bills that passed the full House yesterday, I believe this is one more common sense reform which will minimize hospital overutilization, cut down on unnecessary red tape, eliminate unnecessary costs of Medicare program, and focus on what is best for the patient. Why should a beneficiary have to go to a hospital, have a doctor diagnose the need for nursing home care, all while remaining in the hospital, costing the system thousands of dollars? The CARES Act fixes this one step, lets doctors decide the best care delivery system without burdening the cost of a 3-day hospital stay, and helps protect the solvency of Medicare. And I look forward to working with my colleagues on both sides of the aisle to try and move this legislation. Thank you, Mr. Chairman, and I yield back.
Thank you, Mr. Renacci. Dr. Bustani, you're recognized for 5 minutes. Thanks for your leadership in healthcare.
Thank you, Mr. Chairman. I want to thank you and fellow members of the Ways and Means Committee, the Health Subcommittee, for holding this hearing and for hearing our priorities through a regular legislative order. I think this is really important, and especially with an emphasis now on strengthening the Medicare program, which is a vital program.
As you all know, the Medicare program was established in 1965 to provide reliable health coverage for America's seniors, and we all know there are significant challenges ahead to preserve and strengthen this program. And I'm convinced that we cannot really truthfully and effectively solve the problems with Medicare unless we fully embrace innovation and the latest technology that comes online to improve the health and the lifespan and the quality of life for our seniors. I can tell you as a longtime practicing cardiovascular surgeon, I saw an explosion of new technology just in the time I was in practice that made major differences, huge differences in the lives of seniors, and that continues today. I'm proud to join my Ways and Means colleague, Richie Neal, as well as colleagues on the Energy and Commerce Committee, Gus Bilirakis and Tony Cardenas, to introduce H.R. 5009, called the Ensuring Patient Access to Critical Breakthrough Products Act. This legislation provides an accelerated route to FDA approval and subsequent limited coverage under Medicare in order to stimulate the development of important new diagnostics and treatments that address currently unmet medical needs. For instance, following FDA approval, it can take upwards of 3 years to receive a reimbursement code under Medicare, delaying patient access to groundbreaking technology. This is just unacceptable. We can do better. And while this legislation continues to allow CMS to remain the final arbiter for extending permanent coverage of this limited universe of medical device technology, this legislation is a very important step to enhancing access on the front end to this cutting-edge diagnostic and treatment technology for America's seniors. Many examples exist. I've talked to a number of our companies, particularly in the heart valve technology arena, where they've moved to advanced technology now. For instance, instead of having to cut open the chest and spread the ribs and the sternum, they can do this through percutaneous technology to save lives and morbidity and truly help people who might not have even been candidates for open heart surgery because of other existing comorbidities. That's just one example of the many advances, but if we're caught whereby after going through a lengthy FDA process, CMS delays the implementation and the use of this technology because there's no reimbursement code, then, I mean, this technology sits there and it's not accessible for seniors. This legislation is a modest approach to addressing this logjam and helping to move this technology forward. And so I look forward to working with the committee and hope we can mark up this bill. Thank you, Mr. Chairman. I yield back.
Thank you, Dr. Bustani, for your leadership. With that, the gentleman from New Jersey, my friend, Mr. Pasquarello, member of the subcommittee, is recognized for 5 minutes.
Thanks, Mr. Chairman. Thanks for putting us together. There's some things we disagree with. There are a lot of things that we do have in common, though. So today's hearing, I want to touch 3 subjects, if I may. Huntington's Disease Parity Act, H.R. 842, the Huntington's Disease Parity Act, with my friend Congressman Adam Kinzinger from Illinois. To date, the bill has 253 bipartisan co-sponsors, which in 15 from our committee alone, and of itself makes this bill, I think, worthy of consideration. Huntington's disease, or HD, is a genetic neurodegenerative disease that causes total physical and mental deterioration over a 10 to 25-year period. Because it is a genetic disorder, HD profoundly affects the lives of entire families, emotionally, socially, financially, like a lot of other diseases, too. This devastating disease has no treatment or cure and slowly diminishes an individual's ability to walk, to talk, and to reason. Today, I will focus on the one provision of the bill which would waive the 2-year Medicare waiting period for individuals with HD. Under current law, once a person with HD is deemed eligible for disability benefits, which is a challenge in itself, they are then forced to wait 2 more years before they can receive Medicare benefits.
This means that while people are in the grips of a terrible, all-consuming degenerative disease, they can often not access the range of healthcare services they desperately need. This is simply unacceptable, Mr. Chairman. I thank all my colleagues on the Ways and Means who joined with me in this legislation. Second thing is preserving patient access to post-acute hospital care act. I'd like to highlight H.R. 4650, the Preserving Patient Access to Post-Acute Hospital Care Act, which I introduced with my friend Congressman Vern Buchanan. As the co-founder and co-chair of the Congressional Brain Injury Task Force, I understand the important role that long-term care hospitals play in the recovery of many individuals who suffer moderate to severe traumatic brain injuries or TBIs. If there's one thing that I've learned about TBI in the 16 years I've been working on this issue, it's that recovery looks different for everybody, everyone. That is why we must preserve access to all post-acute care options so patients can receive the individualized care that they need. H.R. 4650 would provide an additional 2 years of relief from the full implementation of the 25% rule for long-term care hospitals. I'd also note that the industry has offered to extend the current moratorium for a long-term care hospital to help offset the cost of the bill, which is something that I hope the committee would consider. And my final point is this, Mr. Chairman, something you've heard me speak about too many times probably, and that is the UDI in claims, more than a few times. I just want to touch briefly on it being included in the medical, the medical device, unique device identifiers, the UDIs, in health insurance claims. This is an important patient safety measure that would improve post-market surveillance of medical devices to help identify problems with devices more quickly and improve Medicare program integrity. I was very pleased last month when CMS Acting Administrator Andy Slavitt expressed support for the important policy. I look forward to working with you, Mr. Chairman, Mr. Ranking Member, to get this done, and I thank you, and I yield back, Mr. Chairman. Thank you.
Thank you, Mr. Pascrell. We will go from Jersey to Philly. Representative Meehan, you're recognized for 5 minutes.
It's a great route, isn't it, Mr. Pascrell? Thank you, Mr. Chairman, and the full committee for your participation, allowing us this opportunity. And I appreciate the opportunity to speak about H.R. 4212, which is the Community-Based Independence for Seniors Act of 2015, which I introduced with our colleague, Representative Linda Sanchez. The bill would authorize community-based institutional special needs plan demonstration program to provide home and community-based long-term services and supports to low-income Medicare beneficiaries who need assistance with at least 2 activities of daily living. Under current law, Medicare does not typically provide coverage for community-based long-term care services and supports, which include medical and personal care, such as assistance with bathing or managing medications. And one study found that 13% of seniors spent down their savings in order to qualify for Medicaid. The demonstration program is designed to eliminate the need for Medicare beneficiaries who receive a low-income subsidy to spend their savings and become dependent on Medicaid. Many seniors prefer to remain in their homes. In fact, they're more healthy as a result of it, to receive the care that they need, and home and community-based care holds the promise of keeping seniors healthy and avoiding costly care. The demonstration offers up to 5 Medicare Advantage plans to provide coverage for long-term care services. The plans will receive a per member per month payment not to exceed $400 for providing these services. And eligible Medicare beneficiaries with CBI SNP in their area have the option to enroll in the plan. HHS will evaluate whether providing home and community-based services to Medicare beneficiaries reduces state and federal government health care spending through delaying Medicaid eligibility for low-income seniors and reducing the need for acute care. The demand for long-term care services and supports will continue to increase. The population of seniors 85 years and older is estimated to more than triple by 2050, and this group is 4 times more likely to use long-term services and supports compared to seniors aged 65 to 84. This program is one step towards reforming long-term service and supports that can generate savings while allowing seniors to remain healthy at home. A similar version of my legislation was reported out of the Senate Finance Committee last year, and I asked for the chairman's support in advance of H.R. 4212. I also want to highlight the arbitrary and capricious manner in which CMS is making decisions regarding eligibility to participate in Medicare programs as a hospital. CMS must not establish or change a substantive legal standard governing the eligibility of organizations to furnish services or benefits unless the agency uses notice and comment rulemaking. However, CMS has done just that in a ruling that will make a determination that Wills Eye Hospital is not eligible to participate in Medicare as a hospital. In contrast, the Pennsylvania Department of Health in the state of Pennsylvania, the survey agency determined that the hospital satisfied the Medicare conditions of participation and should be licensed under Pennsylvania law as an inpatient hospital. And I asked the chairman to work with me to ensure that CMS is using known standards in making determinations regarding hospital status for purposes of the Medicare reimbursement. And lastly, I want to note with Ranking Member McDermott, I am working with him on the Beneficiary Enrollment Notification and Eligibility Simplification Act, also known as the Bennies Act. And as many of you know, Medicare enrollment rules are complex, and seniors do not receive notice from CMS regarding their responsibility to enroll. And because of these confusing rules, seniors may find themselves subject to a late enrollment penalty. The Part B late enrollment penalty permanently increases a beneficiary's premium by 10% for every 12-month period the beneficiary could have had Part B coverage but did not. Others are paying for private coverage that is a secondary coverage to Medicare, but without enrolling in Medicare, these seniors will find themselves responsible for significant out-of-pocket costs. One part of the solution is to require CMS in cooperation with the Social Security Administration and the IRS to issue notifications to individuals approaching eligibility about the enrollment rules and the coordination of Medicare coverage with other health insurance coverage. I appreciate the consideration of my colleagues, and I thank you, Mr. Chairman.
Thank you, Mr. Meehan. Welcome to the Ways and Means Committee room. Mr. Mooney from West Virginia, you are recognized for 5 minutes. Turn on there. Thank you.
All right. There you go. Thank you, Mr. Chairman. I do appreciate the opportunity to testify about my bipartisan bill, the Promoting Responsible Opioid Prescribing Act, or the PROP Act. My home state of West Virginia has the highest rate of opioid overdose deaths in the country, more than double the national average. This drug abuse epidemic is a tragedy crying out for action. Addictions ravage our communities, rips families apart, stunts the development of our youth, and harms our economy. The House has already taken some important steps to address this epidemic, but much more remains to be done. One solution is my bipartisan bill, the PROP Act, H.R. 4499. This bipartisan bill removes a harmful provision of the Affordable Care Act that places unnecessary pressure on doctors and hospitals to prescribe narcotic pain medication regardless of whether the patient actually needs it. This problem was first brought to my attention by a group of doctors in Charleston, West Virginia, and I thank them for that. These doctors, many of whom serve Medicare patients, describe the dilemma they face when treating pain. Either prescribe narcotic pain medicine to patients who do not need it, or risk receiving a low patient satisfaction score and a subsequent cut to the reimbursement rates. This dilemma is a result of a well-intentioned policy that is having unintended negative consequences. In 2006, the Center for Medicare and Medicaid Services, CMS, and the Department of Health and Human Services, HHS, developed a survey called the, quote, Hospital Consumer Survey of Healthcare Providers and Systems, close quotes. We know it as HCAHPS. HCAHPS is a standardized survey used to measure patient perspectives and satisfaction on the care they receive in hospital settings. At first, hospitals use the survey on an optional basis. However, when the Affordable Care Act became law in 2010, it put in place, quote, pay per performance provisions that use these survey results as a factor in calculating Medicare reimbursement rates for physicians and hospitals on, quote, quality measures. The survey includes 3 questions related to pain management, including one that asks whether patients feel that their caretakers did, quote, everything they could to help, close quotes, with pain. While these questions are clearly intended to help patients, doctors tell me that these questions pressure the doctors to overuse prescription pain narcotics when treating patients. At a time when prescription pain abuse is rampant, this is deeply concerning. Doctors, not the federal government, know best how to treat patients. And that includes the question of how best to use narcotic pain medicine. The PROP Act would remove the 3 pain management questions from consideration only when CMS is conducting reimbursement analysis. However, the patient will still answer the pain management questions in their HCAP survey so hospitals can monitor how they're doing. By severing the relationship between HCAP's question on the pain management and reimbursement, we can remove undue pressure on doctors to prescribe unnecessary opioid medications. This simple change will reduce access to narcotic pain medication for patients who do not need it, thereby reducing the risk of addiction. According to the National Institute on Drug Abuse, people who abuse opioid painkillers are 19 times more likely to start using heroin than people who do not abuse those painkillers. In addition, CMS is fully able to implement the PROP Act. The agency has already provided my staff and this committee with technical assistance on the bill. If the bill passes, CMS will simply remove the questions from reimbursement calculations during the next rulemaking session. I'd like to thank the staff from this committee for their help with that. The PROP Act is also broadly supported by groups active in this field, including the American Hospital Association, the American Medical Association, Physicians for Responsible Opioid Prescribing, Association of American Medical Colleges, and America's Essential Hospitals. It's also been introduced in the Senate by Senators Johnson, Manchin, Capito, Barrasso, Blumenthal, Markey, Toomey, Ayotte, and King. Finally, I want to thank many members of the Ways and Means Committee who are already co-sponsoring the PROP Act: Tom Price, Diane Black, Tom Rice, Pat Meehan, Earl Blumenauer, and Bill Pasquarello. Thank you, Mr. Chairman. Your consideration.
Thank you, Mr. Mooney, for your leadership on the PROP Act. It's one that I've heard about, too, back in my district in Ohio, as we've talked about, so look forward to working with you.
Thank you
for being here.
Sure.
Before I turn to Mr. Larson for 5 minutes, I wish to inform him that a member of the subcommittee was going to object to you being here, but I don't see him right now, so be prepared if he comes back in the room.
Mr. Chairman,
Mr. Crowley.
On behalf of Mr. Pasquarello, I'd like to object to.
Mr. Larson, you're recognized for 5 minutes. Can you turn on your microphone? Thank you.
Thank the chairman for interceding on my behalf. We were just on one of Mr. Pasquarello's shows. I'm sure he's perplexed after that show. So in keeping with the spirit of the meeting, let me first start by thanking Kathy McMorris Rogers, as well as our colleagues Tom Reed and Kurt Schrader, on introducing H.R. 3244, which is Providing Innovative Care for Complex Cases Demonstration Act of 2016. Mr. Chairman, this bill would create a demonstration program in Medicare that would allow for contracts in several different parts of our country to be awarded with either a high-quality Medicare Advantage plan or physician organization, ACO, to provide an innovative care plan for the highest cost Medicare beneficiaries in this area. As the chairman knows more keenly than most, that the hardest to serve population at the end of stages in their life is the most costly that we face in terms of the Medicare programs that serve this nation so well. What this bill does, in short, is to provide more benefits, lower out-of-pocket costs, provide an integrated care model, and set high-quality standards. Well, what it does, in short, too, Mr. Chairman, is something I believe this committee should always subscribe to, and that's combining the very best that public health and the government side of the ledger can bring to bear, along with the innovation and technology of the private sector and academic research organizations that we have to lower the costs of health care in a way that's most efficient and productive. It's no mistake that when we were looking at the Affordable Care Act, that there was somewhere in the neighborhood recommended by several agencies that there's somewhere between $700 and $800 billion annually in fraud, abuse, and overlap of responsibilities that take place within the healthcare system. This can be eliminated. We know this can happen in large part because of, well, innovators like the Aetna in my district in Hartford, Connecticut, where we're fortunate to have an individual who's the CEO who is a visionary and way ahead of his times, a person who recognizes that what we want to do is make sure that we're able to keep people in their own homes, that they're able to stay there and provide for the needs. It's a place that they all want to be. And in the process, if we can keep them out of the hospital, nobody wants their loved one to acquire staph infection while in the hospital. Nobody wants to have to be remitted after a hospital stay because of a lack of follow-up care. No one who has a loved one with a chronic health condition like heart disease or diabetes wants their health to be compromised because of a lack of coordination amongst healthcare providers. What this bill will do is provide innovations. What it will provide is an opportunity for us to keep people in their homes in an integrated fashion by coordinating their care in a systemic manner that will allow us to impact the costs and also provide the patient with the best possible outcomes, Mr. Chairman. I'm proud to be a sponsor of this, and I think this is a prime example of how we can work together across the aisle by sharing the vitality of ideas and everything that technology and innovation and, frankly, that the public health system can bring to bear, and then from a human standpoint, recognizing what the citizen and what the people want. In the final stages of life, they want to be in their homes, and we ought to be able to come up with the innovation and a way to do it. Mark Bertolini, the CEO of the Aetna, recognizes this and is one of the leading thought thinkers with respect to innovative healthcare designed to reduce these costs so we get away from the near 20% of our gross domestic product that healthcare ends up costing. So, Mr. Chairman, I again want to congratulate my co-sponsors, especially Kathy McMorris-Rogers and our colleague Tom Reed, and also Mr. Schrader for their support of this bill, and I thank you for the opportunity to testify before your committee and hope it will be taken up during this brief session.
Thank you. Thank the gentleman from Connecticut. I've heard a little bit about that. The Aetna has a large presence in Ohio, and I'm kind of surprised that you promoted a gentleman with an Italian last name as being intelligent and thought-worthy.
Well, unlike Mr. Pasquale, he has a vowel at the end of his name. But thank you, Mr. Chairman.
I thank the gentleman. The gentleman from New York is recognized for 5 minutes.
I believe Mr. Pasquale would also have objected to my testimony today as well. So on his behalf, I'd like to object to my testimony. But thank you, Mr. Chairman and Mr. McDermott, for this opportunity to join you today as we hear proposals to strengthen the Medicare program. I'm glad to have the opportunity to talk about legislation I put forward to address what must be a priority within the Medicare program. Training the doctors we need to meet the health care needs for tomorrow. And I thank Mr. Davis, who I believe spoke earlier about this particular bill. This is not something we can take lightly. Estimates indicate that by 2025, we'll have a shortage of up to 95,000 doctors, both primary care doctors and specialists in the United States. Our health care needs are only growing, with a greater importance on preventative care and comprehensive health and an aging population. 10,000 Americans turn 65 every day, so it is clear we need to have doctors available to treat them and Americans of all ages. Important steps have been taken. Medical schools have worked to increase their enrollment and their graduating classes. But what a lot of people don't realize is that once those students graduate, they need to complete another stage of training by doing a residency program at one of the nation's teaching hospitals. Without completing their residency, they cannot become licensed to practice medicine. Unfortunately, growing numbers of smart, well-prepared medical school graduates are fighting for a stagnant number of residency slots. We're not just facing a physician shortage, we're facing a physician bottleneck. But there is a clear path forward. For generations, training doctors has been a shared responsibility of the federal government and teaching hospitals. And that's because it's a shared benefit. The whole country benefits from more well-trained doctors. Congress has long recognized the value of investing in doctor training. And as a result, the Medicare program helps to support doctor training programs by funding residency slots around the country. However, there is an arbitrary cap on the number of residency slots that Medicare will support, and this cap hasn't been raised in nearly 2 decades. Teaching hospitals have done their part in stretching their funds as far as they can go to help fund additional residency positions, even beyond the Medicare, which Medicare covers. But they cannot do this alone. We must act and act soon to raise the Medicare cap on residency slots. There's no way to create more doctors overnight, but we can make the changes now that will open up the doctor training pipeline. I've put forward bipartisan common sense legislation, the Residence Physician Shortage Reduction Act, to increase the number of Medicare-supported residency slots by 15,000 over 5 years. And I'm pleased to have been joined in this effort by Dr. Charles Bustani, a member of this committee and someone who I think all of us respect for his experience. After all, who better to stress the importance of medical training than a cardiovascular surgeon? Over 125 members of the House, including many members of this committee, have joined us as co-sponsors of this bill. This bill would further address our doctor shortage issues by directing half of the new slots to go to specialists that are determined to be running a shortage. And it makes a decisive statement that we need to make a strong investment in our doctor training program. That is particularly important if we should see continued proposals to cut or weaken the impact of graduate medical education funding. Far from being a luxury, teaching hospitals depend on this funding to fulfill their mission. It is an investment, not just in dollars and cents of running a teaching hospital, but in the highly complex and costly patient care missions that teaching hospitals undertake. They run advanced trauma centers and burn units. They see more complex patient cases. They treat patients with rare and difficult diseases like Ebola. And that helps train future doctors in all those areas. Graduate medical education payments were designed by Congress to reflect and encourage and reward all those efforts. And in a time of changing health care, teaching hospitals are doing more to train residents in community care settings and to give residents the skills for exactly the kind of coordinated care that our system is moving toward. So I urge all my colleagues on the committee to allow our teaching hospitals to continue to thrive in the mission of training the next generation of physicians. That means maintaining our investment in graduate medical education funding, and in what I hope will be a priority for this committee, it means lifting the outdated cap on residency slots, Mr. Chairman. It's not exaggerating to say the future of our health care system depends on just that. And with that, I yield back.
Thank you, Ms. Crowley. Appreciate your testimony today and bringing the matter to our attention. We'll stay in the state of New York and recognize and welcome to the committee room, Ways and Means Committee room, Mr. Zeldin for 5 minutes.
Thank you, Mr. Chairman, and thank you for the opportunity to present my bill, H.R. 3229, to provide for the non-application of Medicare competitive acquisition rates to complex rehabilitative wheelchairs and accessories, an important piece of legislation which would have a significant impact on individuals with severe disabilities. Complex power and manual rehabilitative wheelchairs and related accessories are mostly utilized by a small percentage of individuals who suffer from significant disabilities such as ALS, cerebral palsy, multiple sclerosis, muscular dystrophy, spinal cord injury, traumatic brain injury, and many more. Within the Medicare program, these individuals represent less than 10% of all Medicare beneficiaries who use wheelchairs, making them an extremely vulnerable group of people suffering from significant disabilities. The specialized equipment these individuals rely upon for daily life is provided through a clinical team model and requires evaluation, configuration, fitting, adjustment, or programming before it can be properly used. This small population of individuals has the highest level of disabilities and requires these individually configured wheelchairs and critical related accessories to meet their medical needs and maximize their function and independence. In 2008, Congress passed and the President signed into law the Medicare Improvements for Patients and Providers Act, MIPA, which established a fixed price schedule for complex rehab technology, CRT, and related accessories. Under MIPA, CRT devices would be excluded from CMS's competitive bidding program to ensure consistent and fair prices for consumers. Excluded devices include power wheelchairs and related accessories, which are the fundamental parts of the products that make them useful and beneficial to people with progressed disabilities, such as reclined tilt systems, specialty controls, and seat back cushions. In November 2014, however, CMS issued a ruling contrary to MIPA, which stated that beginning in January of 2016, accessories that are used on complex rehabilitative wheelchairs will no longer be a part of the fixed fee schedule, but will now be subject to competitive bidding prices, which will decrease access to the individually configured wheelchairs and accessories relied on by adults and children with disabilities. While Congress acted to temporarily delay this measure until 2017, further action is needed to permanently address this issue. My legislation, H.R. 3229, seeks to codify the 2008 MIPA regulations and excludes power and manual wheelchairs and their related accessories from the competitive bidding process. In addition to the significant support from groups such as the ALS Association, Muscular Dystrophy Association, National Multiple Sclerosis Society, Paralyzed Veterans of America, Vets First, the United Spinal Association, and the Christopher Reeve Foundation, just this past week, the Government Accountability Office issued a report to Congress regarding the benefits of this legislation. This GAO report focused on utilization and expenditures for Medicare wheelchairs and accessories, and how the 2016 competitive bidding program adjusted payment rates for accessories, and how those rates compare to the 2016 unadjusted fee schedule payment rates for the same items. In addition to recognizing that CRT wheelchairs and accessories are acquired by individuals with high levels of disabilities, the report also details that these wheelchairs and accessories are not standard wheelchairs, and they are individually configured to each person utilizing this technology to meet their specific needs. The report further states that the information CMS is relying upon to shift these wheelchairs and accessories from a fixed price schedule to the competitive bidding process is based on limited information from only 9 of 109 total bidding areas, which is clearly insufficient in order to nationally shift policy. In fact, the report shows that this shift will bring about significant payment cuts, ranging from 10 to 34%, which will only result in increased costs which are passed along to the consumer. My legislation is a common sense approach to addressing one of the significant issues currently affecting the Medicare system. This broadly bipartisan legislation is supported by well over 100 members in the House, and its companion bill, Senate Bill 2196, also enjoys significant bipartisan support in the Senate. This legislation ensures that those who are in need of the most assistance are not unfairly impacted by this new policy shift. Mr. Chairman, thank you again for the opportunity to testify on behalf of this essential piece of legislation, and I yield back the balance of my time.
Thank you, Representative Zeldin. Glad to have you here. And last but not least, welcome to the Ways and Means Committee room, I think the Dean of the New Jersey delegation, Representative Chris Smith.
Mr. Chairman, thank you very much. Thank you, Ranking Member. As co-founder with Ed Markey some 16 years ago of the Congressional Alzheimer's Task Force, and as co-chair for the past 16 years, I'm very grateful to you for providing me with the opportunity to speak about my bill, H.R. 1559, the Health Outcomes Planning and Education for Alzheimer's Act, which now has 286 co-sponsors, including many members of this subcommittee. It is very appropriate that we're discussing hope today, as June is Alzheimer's and Brain Awareness Month. As I'm sure you're aware, well over 5 million Americans suffer from Alzheimer's or related dementia, and as the baby boom population ages, that number is expected to skyrocket unless we find a cure or at least delay onset. This disease is devastating We all know people who have had it, and friends and family members, to both the patient and family alike. Shockingly, many Alzheimer's patients do not receive an accurate diagnosis, especially in the early years. And according to the Alzheimer's Association, fewer than half of individuals with Alzheimer's are even told of their diagnosis. The 200,000 Americans malaffected with early onset Alzheimer's are especially likely to get an inaccurate diagnosis. Alzheimer's is also the most expensive disease in America and incurs catastrophic costs to Medicaid and to Medicare, approximately $236 billion in 2016 alone. On average, Medicare spends 3 times more on seniors with Alzheimer's than those without. That is to say, about $22,000 for seniors with Alzheimer's per year. To ensure that optimum care to every Alzheimer's patient is provided, we need to find innovative ways to improve the quality of care. Occasionally, such initiatives will actually reduce, I say again, reduce Medicare spending. The HOPE Act would amend the Social Security Act to add an additional one-time benefit for care planning services for Medicare beneficiaries newly diagnosed with Alzheimer's disease and related dementia. This one-time comprehensive care planning session will arm patients and caregivers alike with the facts, prognosis, and options for the most efficacious treatment plan that they might pursue. Comprehensive care planning will mitigate huge unnecessary costs associated with preventable trips to the hospital and the emergency rooms. As far back as 10 years ago, an article in the Journal of American Medical Association entitled Effectiveness of Collaborative Care for Older Adults with Alzheimer's Disease in Primary Care, Christopher Callahan wrote that there was a savings in a Healthy Aging Brain Center study that found a $3,500 net Medicare savings when it included such a care planning session. So if people know the facts, they're more likely to get the care they need earlier rather than later, again, averting hospital stays and also taking drugs that might have adverse impacts because of drug interaction. I'll just give you one example that many people are not aware of. Aricept, which is prescribed to treat symptoms of Alzheimer's, can be rendered ineffective when used over-the-counter medicines with over-the-counter medicines such as Sudafed. Very often that's not known, and again, the drug is not having its positive impact that we would hope that it would have. I'd finally point out that I would ask that some or all of the report be made a part of the record.
Without
but a group
objection.
called HealthSpirin, a Washington, D.C.-based healthcare consulting firm, conducted a cost estimate for HOPE. They did it at the behest of the Alzheimer's Association, and they found that as a result of this legislation, net federal health spending would decrease by $692 million over a 10-year period. And again, most of those savings to Medicare would be the result of reduced hospitalizations and emergency room visits, as well as better medication management and better management of comorbidity, which of course is a major problem with people suffering with Alzheimer's. I do hope the committee will consider the bill. It already has a huge majority of the House supporting it, and I yield back the balance of my time, and I thank you.
Thank you, Congressman Smith, your leadership, not only on this bill, but for your leadership on the issue over the years, over the last 16 years.
Thank you, Mr.
There is hope out there. So what a great day, Dr. McDermott. Some great ideas, some fascinating testimony, and I'd like to thank, get back to you on that. I'd like to thank all the colleagues who came before us today, both from the committee and outside the committee. I appreciate all the time and work that they have done, that their staffs have done, that our staffs have done as we have started this robust conversation about how we can modernize our healthcare system, including reforms to improve and to strengthen our Medicare system. And I'm happy we've had the time once again to pursue regular order and make a public record of the efforts that can help us achieve that goal. So please be advised that members will have 2 weeks to submit written questions that can be answered later in writing. Those questions and answers will be made part of the formal record. With that, subcommittee stands adjourned.